Hi, my name is Cintia, and I'm a postdoc here in the Department of Surgery, and I appreciate the opportunity of presenting our work here today. So, rehabilitation programs, which are programs developed to help patients improve their fitness level for surgery, are usually in-person and resource-intensive programs with limited scalability. So, the aim of our study was to evaluate the effect of an online, home-based rehabilitation program on surgical outcomes of patients undergoing abdominal colorectal surgery. In our study, we had a prospective cohort of patients who were undergoing surgery in 3 weeks or more, and who were offered a prehabilitation program, which was delivered through a mobile app. In this program, patients were instructed and encouraged to do strength exercises, to follow the Mediterranean diet, and to walk at least 5,000 steps per day. And we did 2 comparisons. So first, we compared patients who were offered the program and actually used it with those who were offered the program and didn't use it. And the second comparison was between prehab users and this other cohort of patients, which I called ERAs only. To explain a little bit more, in October 2017, the app was introduced in our service. And at the time, it only contained information about the ERA's clinical pathway. In May 2018, we introduced a prehabilitation program. But in April 2019, we resumed the version of the app with ERAs only content. So the second comparison was between the prehab users and this other cohort of patients who use the app, but with an other version which only contained information about the ERA's clinical pathway. For statistical analysis, we did linear and logistic regression, and our outcomes were 30-day postoperative complications, length of stay, and 30-day all-cause readmissions. So 212 patients were offered the prehabilitation program, of whom 96 or 45% were actually users of the program. And the ERAs only cohort was comprised of 127 patients. We didn't observe any differences between the groups in terms of age, sex, BMI, ASA category, diagnosis, or surgical approach, that is between prehab users, non-users, or ERAs only. 48% of the prehab users had moderate adherence to the program, and 39% had high adherence to the program, which we define as being active in all the 3 categories in more than 2/3 of the days. Here in this figure, we can see the adherence level among prehab users according to each item of the prehabilitation program. So we can see that most of the patients had high adherence for strength, 5,000 steps, and also diet. In terms of complication rates, we can see here in figure 3 that prehab users had lower rates of postoperative ileus and lower rate of anastomotic leak, and also lower overall rate of any complications. We then did a multivariable analysis adjusting for age, ASA category, surgical approach, concurrent procedures, and presence of anastomosis. And when we compared prehab users with non-users, we observed that prehab users had significantly lower overall complication rates, lower comprehensive complication index score, lower length of stay, and tended to have lower rates of readmissions, although that was not statistically significant. And we then did the same analysis, but then comparing with the ERAs only patients. And we observed that prehab users had significantly lower length of stay compared to the ERAs only patients, but complications, comprehensive complication index score were not different between those groups, and neither was readmissions. So in conclusion, using adherence to the prehabilitation program was modest, but was associated with shorter length of stay and lower rate of complications. One limitation is that prehab non-users possibly had higher baseline risk for complications, which may have prevented them from engaging more in the program and may have accentuated the different outcomes observed between users and non-users, which is why we didn't observe any significant differences between the users and the ERAs only patients regarding complication rates. In terms of future directions, we need to develop strategies to improve adherence to these prehabilitation programs. We should also ideally have multiple formats of rehabilitation programs so patients and providers could choose which formats would work best for them. And we also need to incorporate formal assessment of frailty in future studies on prehabilitation, which is also a limitation of our study that we didn't include this assessment. Thank you for your attention.